Hello everyone, now let us discuss about drugs for bronchial asthma part 1. So first of all, what is bronchial asthma? Asthma is characterized by hyperresponsiveness of the tracheobronchial smooth muscle to a variety of stimuli. The bronchial smooth muscle is hyperresponsive to a variety of stimuli and that leads to asthma. This results in narrowing of the air tubes, increased secretions, mucosal edema and mucus plugging. Asthma is now recognized as two principal variants, extrinsic asthma and intrinsic asthma. Extrinsic asthma, it is more episodic, less prone to status asthmaticus. Whereas intrinsic asthma, it tends to be perennial, that is it occurs throughout the year. Status asthmaticus is more common in intrinsic asthma. Now, the inflammation in the bronchial asthma is initiated by mast cells and the infiltrate is dominated by eosinophils, lymphocytes and mast cells. The initial inflammatory reaction produces a multitude of mediators by following processes. First, release of mediators stored in intracellular granules such as histamine, protease enzymes, TNF alpha. Next is release of phospholipids from cell membranes followed by mediator synthesis. For example, prostaglandins, leukotrienes and platelet activating factor. And finally, activation of genes followed by protein synthesis, which are governed by interleukins and TNF alpha. So, these multitude of mediators will be released following the inflammatory process. And these mediators together, they constrict the smooth muscle, bronchial smooth muscle. They cause mucosal edema, hyperemia and produce viscid secretions resulting in reversible airway obstruction. And the inflammatory perpetuates by cell-to-cell communication and recruitment of more lymphocytes, eosinophils and neutrophils. The bronchial smooth muscle hypertrophy, increase in the population of mucus secretion cells and blood vessels occur over time and damage to bronchial epithelium. This accentuates the hyperactivity and worsens the disease. Now coming to chronic obstructive pulmonary disease or COPD. It is an inflammatory disease where inflammation is dominated by neutrophils, macrophages and cytotoxic lymphocytes. And it is characterized by progressive emphysema and bronchiolar fibrosis. And the loss of bronchiolar elasticity leads to closure of small air tubes during the expiration. The expiratory airflow limitation does not fluctuate over the long period, but there are exacerbations precipitated by respiratory infections, pollutants, etc. Usually, it does not fluctuate over the long period, but it can be exacerbated because of respiratory infections or pollutants. And COPD is clearly related to smoking, and reduction in the smoking or complete quitting of the smoking can reduce the damage that can occur to bronchial smooth muscle. And the bronchodilators, they prevent the closure of peripheral air tubes during the expiration and they afford symptomatic relief in COPD. But improvement in force expiratory volume in the first second, volume in the first second followed by inhalation of short-acting beta-2 agonist is generally less than 15%. Now coming to the various treatment options. The first one is prevention of antigen-antibody reaction. Though this is not the primary cause or the etiology of the disease, it can be avoided. The prevention of antigen-antibody reaction that is possible in extrinsic asthma if the antigen can be identified. The next is blockade of constrictor neurotransmitter by the employment of anticholinergics. And next is mimicking dilator neurotransmitter, that is sympathomimetic drugs. Next is directly acting bronchodilators, Methylxanthines. In the current session, we will be discussing these three topics. The next is neutralization of IgE, immunoglobulin E, by the use of omalizumab. Next is suppression of inflammation and bronchial hyperactivity by the use of corticosteroids. The next is prevention of release of mediators by the use of mast cell stabilizers. The next is antagonism of released mediators by the use of leukotriene antagonist, antihistaminics, and PAF, platelet activating factor antagonist. Now coming to the drug classifications. The various classes of drugs that are employed for the treatment of bronchial asthma are listed here. They are, first we will be discussing about the bronchodilators. In that, beta-2 sympathomimetics. Next is Methylxanthines and next are anticholinergics. All act as bronchodilators. Coming to the examples of beta-2 sympathomimetics, the drugs are salbutamol, terbutaline, bambuterol, salmeterol or formoterol. Here 2 is subtext, not the supertext. Please consider. The next is Methylxanthines. Example of drugs are theophylline, aminophylline, choline theophylline, choline theophylinate. The next is hydroxyethyl theophylinate. Next is doxophyllene. These are the various methylxanthines. The next examples of anticholinergics are ipratropium bromide and tiotropium bromide. Next drugs are leukotriene antagonist. Example are montelukast and zefrilukast. Coming to mast cell stabilizers, the example of drugs are sodium chromoglycate and ketotifen. Coming to corticosteroids, they are subcategorized into systemic and inhalational. Examples of systemic corticosteroids are hydrocortisone, prednisolone, other glucocorticoids. Coming to inhalational corticosteroids, the drugs are beclomethasone, dipropionate, budesonide, fluticasone, propionate, flunisolide and siclisonide. And finally, anti-IgE antibody. The drug is omalizumab. These are the various drugs that are employed for the treatment of bronchial asthma. Now coming to bronchodilators. In the bronchodilators, we will be first discussing about the sympathomimetic drugs. These are adrenergic drugs that cause bronchodilation in 2 ways. The first is beta-2 receptor stimulation. This leads to increase in the cyclic AMP formation in the bronchial smooth muscle, leading to bronchial smooth muscle relaxation. And secondly, increase in the cyclic AMP formation in mast cells and other inflammatory cells leads to decrease in the mediator release. That is inflammatory mediator release. In 2 ways, they cause bronchodilation. And these are used in the treatment of reversible airway obstruction. Adrenergic drugs should be cautious when used in hypertensives, that is hypertensive patients, ischemic heart disease patients and patients treated with digitalis. Now coming to the first drug, salbutamol or albuterol. Salbutamol is also called as albuterol. It is a highly selective beta-2 agonist. The cardiac side effects are less prominent. It is delivered from pressurized meter dose inhalers through inhalation. The onset of action is 5 minutes and duration of action is 2 to 4 hours. The side effects are muscle tremors, which are dose related, palpitation, restlessness, throat irritation, ankle edema and hypokalemia. Oral salbutamol bioavailability is 50% and it is long acting, that is 4 to 6 hours, but not superior in bronchodilator efficacy. Muscle tremor is the major side effect. The dose is 2 to 4 mg orally or 0.25 to 0.5 mg intramuscular or subcutaneous, or 100 to 200 μg by inhalation. Coming to the various dosage forms or the marketed preparations. The first one is Asthma, which is available in 2 to 4 mg tablet, 8 mg sustained release tablet, 2 mg per 5 ml syrup, and 100 mg per meter dose inhaler, 5 mg per ml respiratory solution, 200 mg rota caps, and next marketed preparation is Crossil, which is available in 0.5 mg per ml injection. Next is Salol, which is available as 2.5 mg per 3 ml injection. The next is Ventrolin, which is available as 2 mg per 5 ml syrup and 4 mg and 8 mg CR caps. The next is Derihalin, which is available in 100 mg MDI, meter dose inhaler. The next drug is Terbutalin. It is similar to salbutamol in properties and used for quick reversal of bronchospasm. Regular and long-term use is not recommended and it has diminished responses. The dose is 5 mg oral, 0.25 mg subcutaneous and 250 mg by inhalation. Coming to the dosage forms or marketed preparations, Terbutalin and Bricarix, which is available as 2.5 5 mg tab and 3 mg per 5 ml syrup and 0.5 mg per ml injection. The next is Mesthaler, which is available as 250 mg per meter dose or 10 mg per ml nebulizing solution. The next is Bricanine, which is available as 0.5 mg per ml injection, 2.5 and 5 mg tablets and 1.5 mg per 5 ml syrup. The next is Bambuterol. This biscarbamate ester prodrug of Terbutalin. Bambuterol is a prodrug of Terbutalin, is slowly hydrolyzed in plasma and lungs by pseudocholinesterase to release the active drugs over 24 hours. Reversible inhibition of pseudocholinesterase occurs in dose-dependent manner. Coming to the indication, it is indicated for nocturnal and chronic asthma. Bambuterol is indicated for nocturnal and chronic asthma. The dose is 10 to 20 mg oral. Dosage forms of marketed preparations are Bambudil, which is available in 10 mg, 20 mg tablets and 5 mg per 5 ml oral solution. The next is Bata D, which is available as 10 mg and 20 mg tablets. The next step is Salmeterol. It is a long-acting beta-2 agonist with slow onset of action, which is used twice daily for the maintenance therapy and nocturnal asthma. It is more selective compared to salbutamol and has long duration of action. Salmeterol is more selective when compared to salbutamol and it has a long duration of action. Regular and prolonged usage of beta-2 agonists is not recommended due to the risk of life-threatening attacks. It is indicated that beta-2 agonists are used combined with inhaled steroids, used in combination with inhaled steroids. Coming to the indication of salmeterol, it is indicated for COPD. They reduce the breathlessness by preventing expiratory closure of peripheral airways and abolishing the reversible component of airway obstruction. Coming to the dosage form, Salmeterol, which contains salmeterol in 25 mg meter dose inhaler, 2 puffs, twice a day. In severe cases, 4 puffs, twice a day. Next is Serobid. They are rota caps which are available in 50 mg and 1 to 2 caps twice a day by inhalation. The next is Seroflow, which is available as 125, 250 and 500 rota caps. Next is Salmeterol 50 mg plus fluticasone 125 mg or 250 mg or 500 mg per rota cap. The next is Seroflox, which is available in 125 and 250 inhalers. Combitude inhaler, Salmeterol. The combitude inhaler has 50 μg of salmeterol and either 125 μg or 250 μg of fluticasone per puff, which is nothing but meter dosed inhaler. The new drugs for the treatment of COPD are indacterol, olodacterol and vilanterol. These are the new ultra long acting drugs for COPD treatment. Indacterol, olodacterol and vilanterol. The next drug is formoterol. The duration of action is 12 hours when inhaled. Onset of action is faster than salmeterol. Dose is 12 to 24 μg by inhalation twice daily. Dosage forms are, or marketed preparations are, Foratec, which is available in 12 μg rotacaps, Derifoam, which is available as 12 μg per puff meter dose inhaler. Next is Airtec, FF. The next is Formosone, which contains formoterol 6 μg plus fluticasone 125 μg or 250 μg per puff. The next drug is ephedrine. It is oral sympathomimetic, has alpha plus beta 2 plus beta 1 actions, which cause mild, slowly developing bronchodilation, lasting for 3 to 5 hours. It is indicated for mild to moderate chronic asthma, and due to frequent side effects, it is not used generally. Coming to the next class of drugs, they are Methylxanthines. Theophylline is one of the 3 naturally occurring methylated xanthine alkaloids, caffeine, theophylline and theobromine, which have quantitatively similar action. Theophylline and its derivatives are mostly used in COPD and asthma treatment. Coming to the pharmacological actions, CNS. Caffeine and theophylline are CNS stimulants and primarily affects the higher center. Caffeine 150 to 200 mg produces a sense of well-being, alertness, beats boredom, allays fatigue, and improves performance and increases the motor activity. Higher doses cause nervousness, panic, restlessness, insomnia, and excitements. Still higher doses cause tremors, delirium, and convulsions. Theophylline is more toxic than caffeine at higher doses and stimulates the Methylxanthines. They stimulates medullary, vagal, respiratory, and vasomotor centers. At high doses, vomiting and gastric irritation and chemotrigger CTZ stimulation occurs. Coming to the effects on the CVS, cardiovascular system, it stimulates the heart and increases the force of contraction. Increase in heart rate but decrease in the vagal stimulation, so the net effect is variable. It leads to tachycardia, increased cardiac output and increased cardiac work. At higher doses, cardiac arrhythmias may be seen. Coming to the effect on blood pressure, it is variable and unpredictable. Usually a rise in systolic and fall in the diastolic BP is observed. The vasomotor center and direct cardiac stimulation tends to BP rise. Vagal stimulation and direct vasodilation tends to lowering of the BP. So the effect on the blood pressure is variable and unpredictable. Next is action on smooth muscles. It helps in relaxation. Theophylline is more potent and slow. Sustained dose related bronchodilation is seen. Vital capacity is increased. Direct action due to adrenergic stimulation is seen. And biliary spasm is relieved. But the effects on the intestine and urinary tract are negligible. Coming to the effect on kidneys, it causes mild diuretics. They act as mild diuretics, inhibiting the tubular reabsorption of sodium and water. They increase the vascular blood flow and glomerular filtration rate. The next is effect on skeletal muscles. Caffeine enhances contractile power. In higher doses, it increases the release of calcium from sarcoplasmic reticulum by direct action. Twitch response is seen at low doses, and caffeine facilitates neuromuscular transmission by increasing the ACH rates. Coming to the effects on stomach, they enhance the secretions of acid and peptide. So this leads to gastric irritation, more with theophylline. The next is metabolism. Effect on metabolism, they increase the basic metabolic rate and plasma-free fatty acid levels are increased. Next, coming to the effect on mast cells and inflammatory cells. Theophylline inhibits the release of histamine and other mediators from the mast cells and active inflammatory cells. Coming to the mechanism of action. 3 distinct cellular actions of Methylxanthines have been identified. The first is release of calcium from sarcoplasmic reticulum, especially in skeletal and cardiac muscle. The next is Methylxanthines, they inhibit cyclic nucleotide phosphodiesterase PDs, thereby preventing the conversion of cyclic AMP to GMP to 5-AMP and 5-GMP respectively. So inhibition of PDs will lead to accumulation of intracellular cyclic AMP or cyclic GMP, leading to bronchodilation, cardiac stimulation, vasodilation occurs. So increased levels of cyclic AMP in the concerned cells leads to bronchodilation, cardiac stimulation and vasodilation. And finally, the third action is blockade of adenosine receptors. First is release of calcium. The next is inhibition of cyclic nucleotide phosphodiesterases, PDs. The next is blockade of adenosine receptors. Adenosine acts as a local mediator in CNS, CVS and other organs. So adenosine contracts the smooth muscle, especially the bronchial, and dilates the cerebral vessels. And it depresses the cardiac pacemaker and inhibits the gastric secretion. So theophylline blocks all these actions. It acts as it blocks the adenosine receptors. The next is pharmacokinetics. The pharmacokinetics of theophylline. Coming to the absorption, it is absorbed orally. Rectal absorption from suppositories is erratic. Coming to the distribution, distributed in all tissues, crosses placenta and is secreted in milk. So 50% plasma protein bound. Theophylline is 50% plasma protein bound. The next is metabolism. It is metabolized in liver by CYP-P1A2 by demethylation and oxidation. Coming to the excretion, excreted in urine, 10% of total administered excreted unchanged form. 10% of total administered dose will be excreted in unchanged form. Elimination rate varies considerably with age. Adult T-half is around 7 to 12 hours. In children, the elimination is much faster. The T-half is 3.5 hours. Premature infants, they have prolonged T-half, that is 24 to 36 hours. In high doses, pharmacokinetics change from first order to zero order. This is an important point. At higher doses, the pharmacokinetics change from first order to zero order. Coming to the adverse effects of theophylline, it has narrow margin of safety, CVS and CNS stimulant, and dose-dependent toxicity, GI distress. Rapid IV injection causes pericardial pain, syncope, and even death due to marked fall in BP, ventricular arrhythmias, or asystole. Coming to the interactions, agents which enhance theophylline metabolism primarily by inducing CYP1A2 lower its plasma levels. So dose has to be increased by factor given in parenthesis. Smoking, phenytoin, rifampicin, phenobarbital, charcoal, broiled meat meal. All of them, they increase the metabolism, so dose has to be increased. And drugs which inhibit theophylline metabolism and increase its plasma levels are erythromycin, ciprofloxacin, cimetidine, oral contraceptives, allopurinol. So dose should be reduced to 2/3 in these cases whenever given with these drugs. And theophylline enhances the effects of furosemide, sympathomimetics, digitalis, oral anticoagulants, and hypoglycemics. Next is theophylline decreases the effects of phenytoin and lithium. Coming to the various preparations, first is theophylline anhydrous. The dose is 100 to 300 mg thrice a day, oral. Products are Theolong, which is available in 100 and 200 mg SR capsules, Duralin CR 400 mg continuous release capsule. CR means continuous release capsule. The next is Unicontin, which is available in 400 and 600 CR tabs, that is continuous release capsule. Next is Theobid, which is available in 200 and 300 mg sustained release tablets. The next drug is aminophylline. This contains theophylline ethylene diamine 85%. Aminophylline is nothing but theophylline ethylene diamine. It contains 85% of theophylline. Coming to the dose, 250 to 500 mg oral or slow IV injection. In children, 7.5 mg per kg can be given. Marketed products are aminophylline, which is available in 100 mg tablet and 250 mg per 10 ml injection. The next is hydroxyethyl theophylline. It is available in the dose of 250 mg oral. It is given intramuscularly and intravenously. The marketed products are Derifylline, which contains 100 mg tab, which is available in 100 mg tablet, 300 mg sustained tablet, and 220 mg per 2 ml injection. The next is theophylline ethonolate of piperazine. The dose is 250 to 300 mg oral or intravenous. Routes are oral or intravenous. The marketed products are Kedifylate, which is available in 80 mg per 5 ml elixir, and Ethofylate, which is available in 125 mg per 5 ml syrup. The next drug is doxycycline. The dose is 400 mg once daily or twice daily. In children, 12 mg per kg per day. The marketed products are Doxobit, Doxovent, Doxorin, which is available in 400 mg tablet and 100 mg per 5 ml syrup. Coming to the indications, it is indicated in the treatment of bronchial asthma and COPD. Theophylline causes bronchodilation as well as decrease the release of inflammatory mediators, improves the mucociliary clearance, stimulating respiratory drive, and by augmenting the diaphragmatic contractility. The next is it is indicated in the treatment of apopnea in premature infants. Theophylline reduces the frequency and duration of episodes of breathlessness, apopnea in infants. And finally, coming to anticholinergic drugs. The first one is atropine. Atropinic drugs. The anticholinergic drugs are also called as atropinic drugs. They cause the bronchodilation by blocking M3 receptors. Atropinic drugs cause bronchodilation by blocking the M3 receptors. Two drugs are used here, ipratropium bromide and thiotropium bromide. Coming to ipratropium bromide, it is short acting and duration is 4 to 6 hours. Dosage form, it is available in aerosol. Side effects are antimuscarinic effects, poor systemic absorption. The next is indicated in asthmatic bronchitis, COPD, and psychogenic asthma. The dose is 2 to 6 puffs 6 hourly. The next drug is thiotropium bromide. It is a long acting and duration is 24 hours. Duration of more suitable for severe cases. Dose is 1 rotacap once daily. These are mostly used in combination for synergic effects. Combination dosage forms are salbutamol plus ipratropium, which is available in the marketed products. Dowlin inhaler, 100 mg plus 20 mg per puff, The next is Dowlin, which contains Rotacap, which is a Rotacap. It contains 200 μg of salbutamol plus 40 μg of ipratropium per Rotacap. The next is Dowlin Respules. It contains 2.5 mg of salbutamol plus 500 μg of ipratropium in 2.5 ml solution. By this we complete the bronchodilators topic for drugs in asthma. In the next session we will be discussing the other drugs. Thank you for watching. Please subscribe for further videos on pharmacology and other related pharmaceutical sciences.